The views, comments, and opinions of the following program do not necessarily reflect those of Morris Media Studios, MorrisMediaLive.com, or its affiliates. Listener discretion is advised.
Hello and welcome to another Health from the Inside Out. I am Dr. Cutter, your host for this evening, and we also have with us Siobhan, our biohacker, our co-host. Siobhan, how are you tonight? She's playing possum with us. She doesn't want to tell us how she's doing. I talked to her a little earlier and she said she had a good day and she had a good week. So I know that she's doing well. And when we get our sound together, she'll be right in to tell us. And there she is, the green queen.
The green queen, yes.
Yes, we established green is my favorite color, and she's got green in spades tonight, so I love it, and it matches the embroidery on my coat. So we didn't plan it, but it's working out, right?
It is.
It is. Okay, welcome, welcome. So, everyone, we have a fantastic, actually, series of shows this evening. We have a two-part series, and it's kind of your post-pandemic toolkit, if you will, right? You know, a lot has happened to us during the pandemic, and so we have two shows that are really kind of focused on some specialized areas that are going to help you to progress out of the pandemic and into your life uninterrupted, right? So the first part of our show, we're going to focus on, or the first show in the series, let me put it that way, because it's two parts in a series. But the first show in the series, we're going to focus on what is sometimes an intimate part of the body and sometimes a very, pedestrian part of the body. Actually, literally, it's your foot and ankle. Very important. We don't think about it all the time, just like sometimes we don't think about our hands, but our hands and feet are really kind of the pathway into the world. And our foot especially is kind of a lot of ways like the eyes, the window into the soul. And we're going to talk about that a little later. But we have a special guest who is a specialist in that area that we're going to introduce later on that's going to help us to talk about that. Part two of our two-part series, we're going to focus on the result of all of this time where you've been in isolation with the people that you love and you were idle and you were bored. So next thing you knew, somebody in the house was pregnant. So we're going to talk about pregnancy and what happens in the pandemic in terms of pregnancy and dealing with that, because we have some special populations that are impacted by some conditions that we see in pregnancy. So we really want to talk about that in some really good detail, and we have a fantastic guest on that topic too. So let's go to our first part of this two-part series. And before we get started, I like to kind of talk about some issue that's kind of broad that applies to everybody, and I like to call it our trigger points. And one thing I want to talk about is walking away. I don't mean walking away in anger. I don't mean walking away in frustration. I mean walking away from situations that don't really merit your energy. What we're seeing with the pandemic lifting is unfortunately a surge of homicide and road rage and things like that. We've had some incidents that happened, and I think a lot of it is because somebody is not walking away. The Bible even talks about this, about, kind of letting something go and letting things move on. It's important to do that. And it's not really a measure of who's the tough person in the situation, right? Really, it takes a bigger person and a tougher person to be able to hold their tongue, right? Bring it inside and walk away. And Sun Tzu in The Art of War talks about not engaging in any battles for which there are no spoils. And really, at the end of the day, yelling and screaming at somebody in Walmart, what's the point? So I just want to urge you from the standpoint of safety, mental health, and also for the sake of your freedom in some cases, your life in other cases, and really for the livelihood of your family in some cases, to walk away from conflicts and difficult situations. So that's our trigger point for this part of the two-part series. So let's jump into, this first show for the two-part series. We are going to focus on the foot and ankle. And we have a very special guest with us. It's Dr. Weissman. Dr. Weissman is a podiatrist. And if you don't know what that means, it's someone who focuses on the foot, but not just the foot, the ankle too. They're next door neighbors and they're friends, right? So they work together as a team. So he treats them together. He also focuses on palliative care, wound care, and of course, surgery is a part of podiatry care as well. So we want to welcome Dr. Weissman to the show. Hi, Dr. Weissman. How are you? We have another quiet person here who doesn't want to talk tonight. I know Dr. Weissman is there. I talked to him before we opened the show. I'll tell you a little bit more about him. He's actually been practicing for 20 years, and he's really kind of built a diversified practice that deals in the areas that I mentioned earlier. And he's focused on the west side of the city, and most of his catchment comes from that area. So he's someone with a broad breadth of experience, and I know that we're going to enjoy hearing from him. So when somebody lets me know that we're ready to hear from him, then we're ready to go. Are you there?
Yes, I am. How are you?
Okay. Yeah, Dr. Weissman has a technology team, hence his sons, right, who are helping him put the technology together today. And he dressed up especially for us. He has on his podiatry scrubs. He's got a model with him. So we know we're going to hear a lot from him. And, one of the most frequently asked questions, for a podiatrist, I bet you can guess this, but I'm not going to put you on the spot. But everybody wants to talk about shoes, right? They want to talk about high-heeled shoes. And then I want to talk about flats because I have this thing about flats. So tell us, what is the impact first of wearing high-heeled shoes? What does that do to the foot?
Well, I mean, some people are able to tolerate high heels, funny enough, and actually do well with high heels and can't wear flats.
Well,
and
you know
other
what?
people,
That was me for a long time. When I lived in New York, you put on high heels in the morning, you walk up to the west side and down to the east side, and you come home and you've had on, high heels for hours on end, and you've walked 30 blocks, right? So I know what you're talking about. I can't do that anymore, by the way, but yeah, that's what I used to do.
Right. Shoes play such an important role in the health of your feet.
Yes.
Ultimately, that's a big tool in terms of what we use for managing a lot of the foot and ankle problems that we see. Generally speaking, shoes, with good support are important for plantar fasciitis. Shoes with a wide toe box are important for people with bunions. A high toe box for people with hammer toes. There's shoes that are more stiff and rigid for people that have forefoot pain. There's shoes that are softer and more accommodating for people that have trouble lifting their feet and maybe some muscle weakness. So it's really important to find the right shoe for you and for your condition that you're trying to deal with.
Yeah, I agree with you. And for those of you who don't know, when we talk about things like bunions, the bone on the side of your big toe that sometimes on some people sticks out a little bit, that's a bunion. And I know that there's probably a more technical foot and ankle description for that, but that's your Dr. Cutter, I think you can understand kind of description. The hammer toe is when that gets to be so extreme, instead of the toe going like this, it kind of goes sideways on you. Is that right? Yeah, we've got some good pictures. Okay.
Yeah.
And so we actually have a surgical after on the right-hand side. Can you talk to us about what you do just kind of briefly to correct that?
Sure. So, typical presentation, someone comes in with a bunion. Most of the time it's painful, although I do get patients that don't necessarily have symptomatic bunions, and we talk about options for that as well. But generally speaking, there's two types of bunions. There's the traditional structural bunion, which is the bunion that we're thinking about. It's the bunion in that picture you just showed. When you look at your foot or someone else's foot and they have that large prominence and that big toe going over towards the lesser toes, that's typically what we think of as a bunion. But there's also a second type of bunion, which is a more arthritic bunion where the cartilage in the big toe joint has worn down. And when you look at that type of a bunion, you may not necessarily see an obvious bunion or a deformity, yet there's arthritic changes happening in that big toe joint and can be equally or even more painful than a structural bunion.
Right.
In general, when I see patients with bunions, there's two options. One is to kind of accept the bunion and treat it non-surgically, and the way we do that is, by wearing appropriate shoes with a high and wide toe box. We talk about using, separators sometimes between the big toe and the second toe to keep that big toe from rubbing against the second toe. Really important to make sure that the mesh or the material on the shoe is soft and accommodating to stretch out for the shoe. You can simply take the shoe and place it next to your foot and make sure that the shoe is wider than your foot. If it's not, it's guaranteed to cause irritation or rubbing.
Right.
So
and we also don't
really,
want it to
really
be too
important.
wide, right? Because you don't want the foot sliding around in the shoe and getting some chafing on the skin and that type of thing. Is that correct?
Absolutely.
Yeah.
Absolutely.
Some people
So
talk
we-
about how as they age or even in pregnancy, their foot increases in size. What's going on there?
Yeah, I mean, the body's dynamic. The foot is a constantly changing structure. Weight-bearing forces place pressure on the foot, and the foot oftentimes splays. People that are hypermobile or flexible tend to get more splaying, and a lot of times we don't have bunions as kids or adolescents, but then as we get older and become seniors, things become more contracted and more prominent. Absolutely.
Okay. One of my colleagues that I ran into today, he recently recovered from surgery for his Achilles tendon. And, I noticed that often happens. The story that I hear, I've had two colleagues that have had this, and it's always, I was going up for a shot in basketball and came down with a problem with my Achilles. What can you tell us about that and ways to avoid that type of injury?
Sure. Achilles tendon injuries, there's Achilles tendonitis, which is inflammation or irritation of the Achilles. And then there's Achilles tendon partial tears where, the Achilles tendon partially detaches, but not completely. And then there's the more common, complete Achilles tendon rupture, where you'll see with basketball players and athletic injuries, high energy type of injuries, although they don't always have to be athletic or high energy. Basically, if you're playing sports, especially for weekend warriors, you've got to stretch. If your Achilles tendon and calf is really tight, you have to think about possibly using a heel lift to accommodate for that tightness. And if you feel a strain or a tightness, you can't ignore that. You have to deal with that. Because the longer something like that goes on, the harder it is to treat.
How long is the recovery for repair of the Achilles tendon? When there is a
So-
problem, how long does that
Yeah,
take?
so after repair of the Achilles, it's usually about 6 weeks off your foot in some type of a splint or a hard cast, and then transition into a walking boot. And then from there, little by little, physical therapy to regain the range of motion, and then transition into shoes somewhere around 8 to 10 weeks. But all in all, it's probably a good 3-month recovery, and then figure until you're back in sports and high-level activity even longer. And that's why a lot of these athletes that have Achilles ruptures oftentimes miss the whole season.
How would somebody know that they're having a problem with their foot? I mean, other than, just pain. Some people don't really have big pain experiences, right? Sometimes I hear people describe things like, oh, I felt something that felt like a pebble in my shoe and I looked down and it was part of my foot. What kinds of things would alert someone to know, hey, I have to go to the podiatrist and get this looked at?
Right. Generally, anything that lingers beyond a certain reasonable amount of time. I mean, we all get aches and pains and strains, but most of the time those things resolve after a week or 2 weeks. Anything that's lingering longer than that, causing you to limp, it's probably something that needs to be addressed. Obviously, there's certain patients or people out there that are higher risk. The diabetic population needs to be even more vigilant check their feet daily. Any type of cut, blister, redness, sore, they need to address that right away. A lot of times the thing I hear from diabetic patients when they're in the hospital is, gee, I developed this thing, I didn't really think much of it, it turned into this, and now here I am at the hospital, and now we're talking about surgery or even amputation at that point. Whereas if you can get intervention and treatment sooner, you could avoid that whole cascade of infection, surgery, amputation,
Right.
etc. So early intervention, especially for diabetic patients, routine visits for those patients is really, really important as well. There's a lot of things that we see as physicians and podiatrists that patients don't see.
Right.
Pressure calluses, and there, different types of sores, skin changes, circulation problems, a lot of things that we can see early on and alert a patient to get treatment or further diagnostic tests before they develop a problem. But then in terms of other people out there, something like a stress fracture, for example, most of my patients that come in with foot pain and swelling maybe for a week or two, they don't even recall an injury, yet they're limping, they have some swelling. We shoot an x-ray. X-rays don't always show anything right away, but sure enough, you take a repeat x-ray 2-3 weeks later, and it shows a stress fracture. And that needs to be treated and immobilized, and it's not necessarily going to get better right away real quick. And the sooner you treat that and immobilize it, the sooner it can heal.
How do you treat a stress fracture? Is that with just pinning like we saw in the x-ray, or what's your technique for that?
I mean, generally stress fractures are basically stress injuries to the bone. They're overuse injuries. Maybe you got a new pair of shoes, maybe you started increasing your exercise activity, maybe you've been walking around the house more barefoot recently, but increased stress load on the bones, especially these long metatarsal bones, which tend to be thinner and more delicate, more susceptible to fractures.
Right.
And basically there's stress and the bone cracks and forms a little stress fracture, but they need to be treated with immobilization and rest just like any fracture. I usually place patients in a walking boot. If they can't tolerate a walking boot, if it's an older patient, then a good rigid sandal, something that doesn't bend and flex, that can rest the foot and allow the body to heal.
I'm really glad that you mentioned diabetics earlier, and you also talked about vasculature and things like that, because I really want to touch on this topic. This is so important. Everybody has a war story, and so this is one of mine. When I was a resident in New York, we had this very nice, beautifully coiffed older woman to come in with a very dark great toe. And what had happened is she treated herself to a pedicure, and the manicurist cut into her foot when she was taking care of the cuticles. So at first it was just a little redness and bleeding, and then it just kept getting more and more red. Then the redness spread through the toe, and the next thing she knew, it was like dark purple. So she comes in, and of course, I'm on the vascular team, in which we also have a podiatrist rotating. We do vascular studies, and we find out that her circulation is poor, and she has calcium in her vessels. Long story short, we tried to revascularize her. We couldn't. She ended up getting an amputation above the knee. So I really want to talk about the importance of circulation, knowing, the status of your circulation, being careful with your diabetic feet. What do you do in terms of assessing someone's ability to heal after one of your surgeries? What do you do beforehand?
Sure. That's a good question. So basically, I look at the color of their skin. I look at things like hair growth. I'm able to appreciate pulses most of the time. Basic circulation. If I'm concerned or if I'm doing surgery on a patient, I want to make sure that they can heal a surgery and optimize their recovery, then I'll send them for vascular studies. They're non-invasive studies that could be done at a hospital or a clinic. And basically that shows the circulation and the ability to heal. And it's generally rated as mild, normal, moderate, or severe circulation disease. Obviously, anyone in the moderate or severe circulation disease category needs to get further workup. I usually end up referring them to vascular surgeon for further evaluation and to see if any intervention needs to be done. And again, the sooner you're able to address that, the better the outcome. You don't want to wait until that toe is black or part of the foot is necrotic or you've developed a wound to deal with the circulation problem. Some of the other questions I'll ask patients is, how far can you walk? We rate circulation as 1 block claudication or a half a block claudication or 2 block claudication. Someone that can walk 2 miles probably doesn't have to worry about circulation problems. But people that can only walk a half a block and then they get calf pain or foot pain and they have to sit down, that's someone that's higher risk for circulatory problems. Even worse than that is someone that gets something called ischemic rest pain, and that's pain when laying in bed, when you're in a horizontal position and gravity is not able to pull that circulation down to the feet, and the tissues are now deprived of blood and oxygen, and you start getting circulatory pain or ischemic pain is what we call it. That's a more severe advanced form of peripheral vascular disease, and that's something that definitely needs to be addressed as well.
Absolutely, and 2 populations that are really at high risk for that type of thing. You already mentioned the diabetics, and then also people who are kind of what I call vasculopaths, the people who are smokers, they've had a stroke in the past, people have had heart attacks. Just keep in mind, everyone, that, when you do have these conditions, it's not just the heart, it's everywhere, right? You've got this disease everywhere. And so you really need to be careful and investigate these areas before you have surgery, especially with the feet, because it's the circulation there, it's kind of the end of the line, right? The heart really has to work hard to get circulation down there. If there's any blockages along the way, it's going to be deprived and healing could be impacted. I really want to bring Siobhan in on a topic. There are a lot of tips out there in terms of how to take care of the skin of the feet. And, Siobhan, I don't know if you came up with anything about, foot care and how to take care of, the skin on the foot. Did you come across any recommendations on that, Siobhan?
I have. So whenever we think about the skin, it's always going to be protein, collagen, vitamin C, everything that supports the integrity of the skin. And because the feet are so delicate and they're always enclosed in shoes and they carry a different type of moisture, it's important that we always look at key components that build skin and optimize the tightness of the skin. So vitamin C, collagen-rich foods, zinc, everything that kind of supports the immune system will also have a benefit on the skin. And like as he mentioned, plantar fasciitis, that's inflammation. So then you want to make sure you're moving towards more of an anti-inflammatory type diet, key nutrients like calcium, vitamin D, as well as vitamin K. Vitamin K plays a key role in supporting the bones. The bones are very delicate in the feet. It's key to understand how different things work in the body and how diet plays a key role. But as far as the skin, making sure that everything that builds healthy skin is something that's in the diet.
Really nice. And, the skin is really important because it's really kind of the portal of entry for a lot of bacteria, which can lead to cellulitis, which is redness and inflammation of the leg. It causes swelling. And in people who have a predisposition to that, so these are some of the people with vascular issues, and again, diabetics and people like that, this can be really very devastating and can lead to infections like necrotizing fasciitis, which is basically flesh-eating bacteria. So I have seen that in a couple of cases. Now, I got some tips online on, what we can do to maintain our foot health. And, Dr. Weissman can kind of chime in on some of these. What are your main tips, Dr. Weissman? And then I'll give you the other ones that I found.
Sure. So, general good foot health in general, I like shoes that are supportive. I like shoes that tend to be more sturdy rather than, more flexible and flimsy and minimalistic. I like avoiding barefoot walking generally. That tends to exacerbate a lot of foot problems. During the pandemic, a lot of people have been working from home, maybe walking around the house more barefoot. All of a sudden, hey, why is my heel hurt? Why does my arch hurt? Well, it's because you've lacked that structure that you're accustomed to having, and as a result, after several weeks of walking around the house barefoot or in slippers or not having that support, you've kind of inflamed that plantar fascial ligament, and now you've got arch pain or heel pain or maybe ball of the foot pain because you don't have that cushioning and that support to to cushion the foot.
Right.
So that's important. And then in general, just good hygiene. Nail care, skin care, dealing with cracks in the skin, moisturizing the skin with creams so you don't get fissures or dry skin. And if you have a lot of problems with that, then seeing a professional and having help to reduce some of that buildup of thickened, calloused skin.
Right.
And that's something that we do regularly for patients. And some of my patients come in every 2 to 3 months for that kind of a treatment, and that's perfectly fine.
So if people want to see a professional, Dr. Weissman, how do they get in contact with you?
So myself or any podiatrist, depending on where you live, you can ask your internist for a referral to a podiatrist. If you're part of an HMO group, you can ask for an authorization to see a podiatrist affiliated with that medical group. If you're word of mouth, if you have a friend, there's a good chance that they've seen a podiatrist, and you can certainly ask for a recommendation. And that's generally probably the best approach. And of course there's the internet and yellow pages and things like that.
There you go. Not my goodness, the yellow pages. Are we going back in time there or what? Listen, this has been great having you, Dr. Weissman. I really appreciate you sharing your expertise. We're kind of at the close of our time. I just want to caution everyone about, cuts and scrapes and things like that on the feet, keeping the feet moisturized, avoiding tight-fitting shoes as much as you can, skipping the flip-flops and the flaps. They're not really very supportive. And then also, practicing good foot hygiene, and stretch your feet before you work out and before you exercise and all of those things. So one thing we didn't get a chance to talk about was reflexology. That's an area that I really wanted to delve into, but we're going to talk about that on another show. So I just want to thank you all for joining us on this segment. This is the first part of our 2-part series on kind of some post-pandemic tips on the head-to-toe area. I'm Dr. Cutter from Curetology, Surgical Oncology, and we've got Dr. Weissman with us and also our co-host, Siobhan the Biohacker. We want to thank you for joining us, and we'll see you next time. Hello and welcome to Health from the Inside Out. I'm Dr. Cutter, your host. We also have our co-host Siobhan, as I lovingly call the biohacker. She's here to give us our health and epigenetic tips and hints so that we can learn more about our bodies and actually how they work. So we are in the middle of a 2-part series of shows kind of focused on the post-pandemic life. I mean, let's face it, a lot has happened over the past year and a half or so, and our bodies have changed. And so we want to address some of those changes so that you can emerge from at least this phase of the pandemic. I'm not going to say it's over because I'm cautiously optimistic, but we want to emerge from this phase of the pandemic ready for action. So in our first segment, we talked about in our first show, we talked about foot and ankle, right? We take that for granted and we walk on that all day. So we did talk about that. We had a fantastic guest. So now we're going to go to another area of the body where, listen, let's face it, all that idle time, people who love each other in close quarters, what happened? We had a lot of pregnancies. And with everyone developing a corona belly from all the food that they ate and the pregnancy together, it can make for some high risk issues. And so we really want to delve into that. So we have a fantastic guest that's going to help us talk about that. Before I jump into that topic, you know, I like to do a little segment called Trigger Points. And for this particular one, I'd like to talk about what love feels like. You know, love feels good. Love is something that is generous and kind. You know, love doesn't hurt. Love doesn't destroy. Love doesn't punish. And unfortunately, during the pandemic, we did have some situations where people were getting into some abuse and some very difficult situations, and they were trapped with abusers. But I'm here to let you know, just in case you were confused about, you know, what should be happening around you, you shouldn't feel bad about yourself, right? And you should not hurt physically or emotionally. If you're in any of those situations, I invite you to call for help. There's a lot of services out there. You can call the city. You can call the county, and you can actually go to any hospital, and they will help to navigate you into a situation that's much safer. You can also go to a school. If you have children in school, you can actually seek help at the school if that's comfortable for you. So I do want to encourage everyone to remember, love feels good. And if you're not feeling good, you may have a problem at home. Look into it, get some help, okay? So that's our trigger point for the day. So let's switch gears a little bit and welcome those who are joining me here on the show. We have our co-host, Siobhan, the biohacker. Hello, Siobhan. How are you this evening?
I'm great. How are you doing, Dr. Cutter?
I'm good. We did segment 1, and so now we're going to jump into segment 2, and boy, do we have a lot to talk about, right?
Yes.
Yes, we do. We do. So we are ready to go. We both have our glasses on tonight, so we are thinking and we can see. Okay, and that's
exactly.
important. But we have a very distinguished person on the panel who is going to be our expert this evening. This is Dr. Ogunyemi. Dr. Ogunyemi is a distinguished obstetrics and gynecologist. And for those of you who are not initiated, that's a specialist in the field of medicine that focuses on women's health issues and also women in pregnancy. He is also a subspecialist in something called MFM, or maternal and fetal medicine. And that's someone who really focuses on high-risk pregnancies. So a very important specialty. So we're going to talk about what makes a pregnancy high risk and all of those things. He has had some very distinguished positions out there: Associate Chief Medical Officer, a Director of Information Officer, I believe this is. I think I have it wrong, so you're going to have to correct me on this because my little abbreviations are not serving me at the moment. Yeah. And he really does focus on medical education. He focuses on some elements for residency training in different institutions. So he has a really kind of a broad impact on medicine and medical education and, of course, the health of women. So I really want to welcome Dr. Ogunyemi to the show this evening. How are you, Dr. O?
Well, fine, thank you. And thank you for your very kind and nice words. I'm greatly appreciative of being able to be part of this with you.
Well, we're glad that you're here because you have a lot to share. And I just want everybody to know this is only a taste of what Dr. Ogunyemi can share with us. We're only going to focus him on this one narrow topic because there are so many other things that he can do. We're going to bring him back another time, and we're going to talk about some of those other things. So, let's jump into it. Now, you and I, in our pre-show conversation and everything, we were talking about a lot of the things that happen as a result of obesity and pregnancy, right? And one of the most devastating is stillbirth, right? So let's talk a little bit about that.
Yes. So again, we know that pregnancy is supposed to be a happy event. People coming pregnant, they're healthy. And when they come to the hospital to have a baby, they want to have a healthy baby, a live baby, because they're looking forward to having their baby. So again, so having a baby that does not survive is one of the most disastrous things in healthcare. And
Absolutely.
so, yes. And so why does that happen? So there are many reasons why that happens, but I'm going to focus on why it happens in women who have excessive weight. And there are about three major reasons why that happens in women who have excessive weight. One is that women who have excessive weight usually may have some sleep apnea that they're not aware of, that's not being treated. And when you have sleep apnea and when you're sleeping, you stop breathing. And when you stop breathing, your oxygen level goes down. If you're pregnant and your oxygen level goes down, you're not aware of it, the baby's not getting enough oxygen and baby may pass away very quickly. So having sleep apnea is one important cause. And so that if you have excessive weight and you're pregnant, it's very important for you to be seen by a pulmonologist to rule out whether you have sleep apnea, and giving you a CPAP will take care of that. So that's one reason why that occurs. The other reason why that occurs is that a lot of people have excess weight also have their blood vessels, the blood vessels that carry blood from the heart to the organ are called arteries. And so there are specific blood vessels called uterine arteries that carry blood to the uterus or the womb where the baby is growing.
Okay.
Now, if you have excessive weight, it's very possible that those vessels get clotted with fatty cells, which you call atherosclerosis. So basically the vessels become narrow and there's no outward sign that you can see that at all. And therefore you have decreased blood going to the uterus, and that also deprives the baby of oxygen and nutrients. And for that reason, the baby is more likely to pass away. The third reason is that women who have excessive weight are also more likely to have complications of pregnancy, other conditions that increase the risk of the baby not making it. One of it is diabetes, another one is hypertension, there's also preeclampsia, and so that's another reason. Then finally, there's actually a much more subtle reason. Now, a good sign of a baby is a baby that moves. A baby that moves is a healthy baby. A baby that's not moving is not a healthy baby. Healthy babies move. So one of the ways we monitor pregnancies is by kick counts. However, women who have a lot of excess weight on the abdomen tend not to feel baby's movements as much. And for that reason, the baby may stop moving and they may not feel that baby, and the baby may pass away because there's not enough attention placed on that. Because normally if the baby stops moving, the mother's supposed to come to the hospital, we check the baby's heart rate. If we see that the baby's heart rate is not doing well, then we intervene and we deliver the baby or do corrections to try to correct that. But if the mother doesn't even know the baby's not moving well, then interventions cannot be given. So again, these are some of the reasons why there's an increased risk of fetal demise or stillbirth in women who have carry excess weight.
You know, the last reason that you talked about is really helpful because that's something that, women can detect. You're right. Those other causes, they really may not know about them. And so, when they do note a decrease in fetal movement, I'm like, hey, I haven't really felt the baby move around in a while. Listen, that's a time to go get some help.
Yeah.
I wanted to quickly.
Can I give something more about that, which is important to women? Is that if you have a normal pregnancy, your baby should move 10 times after a meal.
Okay.
If your baby's not moving 10 times after a meal for 2 hours, that baby's not moving well enough and you need to go get checked out.
Okay, so everybody hear that, 10 times after a meal. One thing I wanted to highlight, because we talked about excess weight, and so some people don't even really realize, if they do have excess weight. So I wanted to throw up an image that I had and then an image that you had. So this one shows what the definition of the obesity diagnosis is. And it shows what it looks like for people who are underweight. And that is, we kind of base this on something called a body mass index, which is a comparison between height and weight in equivalent measurements. And we can get into that, whether it's metric system or pounds or what have you. There's calculators out there. So those calculators will take care of it. But, a BMI of 18.5 or less is almost as bad as having the obese BMI of 30 to 34.9. We see increased problems in both of those groups. And we also see increased long-term effects on the body and decrease in lifespan in those individuals. So Dr. Ogunyemi, I think you also had a table that you wanted to show us that showed the BMI, and then how much weight a woman should gain during pregnancy. Did you give us a table on that?
I have the table in front of me, but so I can read it out to you, if that will help.
Okay, so if we throw back up that obesity slide, and then you can kind of quickly just tell us, if someone is, let's take someone who is underweight. How much weight should they gain during pregnancy?
So somebody who's underweight should gain between 28 to 40 pounds for the whole course of the pregnancy.
28 to 40.
28 to 40. However, the best way to look at it is the last 20 months of pregnancy, how much weight should you gain per week? So somebody who's underweight should probably gain between 1 pound to 1.3 pounds per week during the last 20 weeks of pregnancy. So basically the way that works is that every time you go to your doctor, they're going to check your weight, and they actually have a chart that they put it on. So if you're getting less than that weight, it will show that you're below the curve, and then that person needs some nutritional counseling and advice about diet and how they're eating and what else is going on in the family. Sometimes a major reason why that occurs, especially who are underweight, is that they can't tolerate eating. They have this nausea of pregnancy. They have something we call aparemesis of pregnancy. It's more likely to affect the underweight women, and then they just can't eat because they're throwing up all the time.
Right. So let's go to the person who is in the obese category, someone with a BMI of 30 to 39 and more.
Yes.
How much should they be gaining? And I know that there's a couple of different classifications of that, but in general, isn't it about 0.5 to 0.6 per week?
Oh, yeah, you got that right. 0.5 is the average, but the rate is between 0.4 to 0.6. And they're supposed to gain a maximum of 11 to 20 pounds for the whole period of the pregnancy.
So I think that is something that would be stunning to a lot of pregnant women out there. And I actually took care of a pregnant woman just this week. She came in with gallbladder issues, right? And that's how I end up seeing pregnant women. They have gained all this weight. They start off overweight or obese. They gain a lot of weight during pregnancy, and they come in with gallstones, and they're having all this right upper quadrant pain, nausea, and things like that. And, from a surgical standpoint, we don't really like to operate on pregnant women during the first trimester or the third trimester. The sweet spot is the second trimester for us, and as early as possible in that trimester. Yeah. But she was at 27 weeks. And so what I told her, I said, you've got to switch to a low-fat diet so you don't aggravate the gallbladder, and you just have to kind of cool it until you deliver. What would you tell a woman who is starting to have, these kinds of pains and things like that? How can they address their obesity and the related problems as they go through their high-risk pregnancy?
So one of the things that's very important is to correct the fallacy that you cannot exercise in pregnancy. Exercise is actually approved and recommended in pregnancy. And women who exercise in pregnancy actually have better tone. They may tolerate labor better, and they do better. So again, we do recommend exercise in pregnancy. We don't want you to overdo it. We want you to watch your balance. However, obviously, we don't want you to start excessive exercise or strenuous exercise that you have not done before you got pregnant. And if you work out in the gym before you get pregnant, please go on doing that. So the minimum that we suggest for any pregnant woman is, if it's possible, to take a short walk after meals, because we know that will help to bring down your blood sugars. And there's a recommendation that you should walk 30 minutes after a meal, at least 3 times a week if possible, if at the minimum. And if you can do that every day, that works well. So the first point is some kind of activity is important. The next one, which you kind of alluded to, is, of course, the exercise. Is obviously the diet. So basically, if somebody is overweight or has excessive weight in pregnancy, we actually do recommend that they're seen by a nutritionist, and they will calculate their calories based on their weight, as well as what the expected weight is. What I tell patients very easily, as I tell them to avoid the 4 whites: white sugar, white rice, white flour. So anything white, it makes it easier. Potatoes, anything white, that makes it easy. And just tell them, increase the vegetables. I tell them, just eat them. So actually, when patients come to me and don't have a nutritionist, I just tell them, listen, before we go into the specific calories, let's tell you what you can't eat. Don't eat any more of those fried food. Stop eating fried food. Stop eating the carbs. No simple sugars. No
Right.
sugars. And then
Right.
focus on protein as well as vegetables.
Right. So those healthy dietary habits, those all make a difference. And I just want to mention to everyone some of the other conditions that happen with obesity and pregnancy, things like gestational diabetes, blood pressure disorders, we call that preeclampsia, newborns that are very large for their age of gestation, postpartum hemorrhage, and also risk of cesarean delivery. Dr. Ogunyemi, I think we sometimes see an increase in cesarean deliveries for some of these women, obese women, and then some obstetricians really just prefer cesarean deliveries from a safety standpoint. What are your thoughts on the cesarean delivery, and how can a mother prepare for that?
So we tend to support natural delivery, which is a vaginal delivery. And vaginal deliveries have the least adverse outcome to pregnant women. People who have vaginal delivery recover better. And not only do they recover better, they have less illnesses from delivery. So that when something I say this way is that even though labor is associated with pain, of course, epidural analgesia and all the kind of pain procedures we use decrease that. So, but the point is that either you're having the pain before or the pain afterwards. If you have a vaginal delivery, you have the pain during labor, but we're very good at using epidural to stop that. If you have a cesarean section, you're going to have pain afterwards. There's a significant amount of pain and inability to do the things you normally do when you have a cesarean section, which takes about at least a minimum of 3 days and then may last for 6 weeks. So I think we need to put that into perspective. So now what do we, so the reasons again why cesarean section may be more common in women who have extra weight is one, just like you said before, they tend to have larger babies. And because they have larger babies, they may not be able to navigate through the pelvis. At the same time, they also tend to have some complications that may increase, like the diabetes, the preeclampsia we talked about, that may increase their need of having a quick delivery. At the same time, also the baby, because of the pressure and everything, may not tolerate labor that well and may need to be delivered for that reason. Also, the labor tends to go longer because we use a term called soft tissue dystocia. And dystocia means difficult delivery. And we know sometimes because of all the soft tissue masses, it may actually make it very difficult for the baby to come through. So again, those are the reasons why we tend to have a cesarean section.
Right.
Now,
so how can these ladies, is there anything that you recommend that they can do to prepare for a cesarean section? Or is it just, hey, look, when you come to the hospital, we'll give you instructions and this is just what's going to happen. But is there anything that they can do before they come for that procedure?
Yes, I would first of all start with to prepare to try to make sure you don't have a cesarean section, which is really to try to have a support person, helps decrease the risk of having a cesarean section. A doula, so we think a doula is a very important person who has been shown to actually reduce the risk of cesarean section. Also, not laying in bed, moving around, taking very many different positions help with that. So for you to prepare for a cesarean section, obviously, if you're scheduled for a cesarean section, it's very important for you not to eat before that period. It's also very important for you to know that cesarean section increases the risk of having a clot in your vein, which can really be very serious. And therefore, you have to move around. You have to make sure you don't lay in bed. It's also important for you to know what happens at the first day. Yeah, if you have some pain, we're going to give you some pain medications for that. But it's also important to know that you need to try to get out of bed, and that things like if you don't pee properly increase the risk of infection, and that you also have to start breathing quickly. We'll give you a small, and you're a surgeon, so you know that as well, Dr. Carter. We'll give you this small thing to breathe to, and that helps to clear your lungs so that secretions do not stay in that. And in pregnancy, that's a common problem. So again, these are some of the things you could be aware of so that when you come for a cesarean section, you're ready to help yourself to get better quickly. Also with your baby may have to go to the nursery. And so it's important for you to try to bond with your baby. And then what I think is most important, breastfeeding. Breastfeeding is extremely important. Please don't stop breastfeeding because you've had a cesarean section. You can pump, if you can't do it for the first 2 days, you can pump your breast so that the milk still comes in, and that can be safe for the baby as well. So those are some of the things you could try to think about if you're going to have a cesarean section. And
Okay.
also the scar. One more important thing.
The scar.
No. Yeah, one more important thing.
One more thing.
Once you've had a cesarean section, there's a risk that you may need to have we can support you having another what we call trial of vaginal delivery after a cesarean section. But once you've had 2 cesarean sections, we tend to suggest a repeat cesarean section. However, after 1 cesarean section, there's still a 70-60% chance that you can have a vaginal delivery. And we really think a vaginal delivery is better. However, with a cesarean section, the major risk with a cesarean section is the consideration that the uterus could tear, because we've cut through the uterus, we've sewn it back. That area where it's sewn back is kind of fragile, is a scar, may not heal very well. And with successive pregnancies, there's a possibility that may tear in a pregnancy.
Okay, we're going to have to leave it there on that topic and jump into something else. I want to bring Siobhan in on this one because, there's a lot of women who have had bariatric surgery, right? So we're not just talking about the ladies who currently have a obese diagnosis, but, ladies who formerly had one. And hopefully these ladies who have had bariatric surgery, it's been at least a year, if not more, between when they had that surgery and getting pregnant. And I wanted to bring Siobhan in on this because there's some very serious nutritional deficiencies that can happen with the bariatric surgery. Siobhan, can you talk to us a little bit about what women can do to prepare their bodies for pregnancy and make sure that they don't have these nutritional deficiencies?
So the most common nutritional deficiencies are going to be your B vitamins, because most times they're losing some of that portion of their stomach that supports astringent factors and how the body really breaks down B vitamins. So I would suggest that they go to their doctor and determine the status of like their folic acid, if they're really having a problem with B12, and really get a clear idea how their body is utilizing B vitamins. And if you're having a real serious issue digesting it, then go to sublinguals and do some IM injections or some micronutrient IVs. It's very important. Yeah. But there's other ways to bring up those levels.
Yeah. And iron is also an issue as well, making sure that, there's a bunch of anemias you can have. And, Dr. Ogunyemi did a great job of talking about the importance of having adequate oxygen to the uterus so that the baby has adequate oxygen to grow and to thrive and to remain viable. And so iron is another one of those elements. What kinds of things can ladies do to make sure they have enough iron in their diets?
So folic acid and iron are always the nutrients that are highlighted, right? They're always in the limelight. Yeah. Iron is best coming from the diet. But if you have a serious deficiency, if you have any inflammation of the digestive system and you're really having a problem extracting iron from whole foods, then it's important that you understand how to properly supplement to get in iron. But I like a high biological value source of iron like liver. So a good diet when you're pregnant is a Mediterranean diet with modifications. Where you're taking
I love that diet. Yes, Mediterranean diet. Let's go. Yes, tell us more.
And it should be modified, right? You need to modify that diet because that diet's very low in red meat. And the red meat that I often recommend is either beef heart or liver, and it's something you should have every other day. And of course, you want to talk to your doctor, but you want to take out all pasta, all bread, everything white. The rices that I recommend are going to be brown white rice, wild rice, and black rice. And the other modification to that diet is because it's so high in legumes, and if you're having issues digesting and utilizing vitamins and minerals, there's some anti-nutrients. And you want to make sure that they're not getting in that phytic acid from legumes. So I often recommend lentils and make sure they're properly soaked, making sure that people that have issues with vitamins and minerals, that they're not getting in oxalates from raw green leafy vegetables, that they are steaming them, boiling them, and cooking them. And I like to go with a double whammy. When you're actually making a human, it is so important that you have a clean diet and you're properly supplementing. I don't like one-a-day supplements. One-a-day vitamins are not ideal. The research
what are ideal vitamins? Food, of course, I think is the best source for nutrients, right? I'm totally with you on that. But if you're a person that you just can't seem to get what you need, and patients who have had bariatric surgery, they can't get it from food. So what's a good source? Well, let me put it this way. What's a good approach to getting that nutrition supplement?
So any supplement that can be sublingual, meaning it goes up under the tongue and it goes right into the bloodstream. Anything that you can actually, they even have certain micronutrients that are suppository, anything where you can bypass the digestive system,
Right.
whether it's IM or IV, if you can bypass the digestive system, then that's ideal. But when it comes to supplementing during pregnancy and supplementation as a whole, we don't eat once a day. Well, most of us don't eat once a day, right? So you need to make sure your supplements are staggered throughout the day. And most of the supplements, through the research, like folic acid, you should take it throughout the day. It's not something you take once and hope that your body can utilize this key nutrient for 24 hours.
Well, I really like that. You know, you don't really hear that enough, I think, about supplementation. You know, it's usually that one a day approach and everything. There are so many things that we could talk about with this topic. And I always feel like we just need like a little bit more time because, you know, we didn't get into talking about proteins. We didn't really talk about the impact of maternal obesity on the lifetime of the child, you know, and I'll just put this bug in your ear. Obese mothers give birth to babies that are set up for obesity and heart disease in adulthood. So if you think it doesn't matter what weight you are while you're pregnant, think about it again. You know, we've talked about so many really good things here today. You know, Dr. Ogunyemi is just, you know, such an expert, not just in this field of OBGYN, maternal fetal medicine, but really in some other things. So we're definitely going to welcome him back to talk about some other topics that have to talk about equity and medicine and all of those things. We love having our biohacker. She's always giving us some insightful tips and hints that we've never heard before. And, you know, every time I hear her speak, I learn something from her. So thank you, Siobhan. Dr. Ogunyemi, just really quickly, if people want to get in contact with you, is there an email address, a phone number, or a website that you want to send them to? Really quickly, 10 seconds.
DOGUNYE@outlook.com.
One more time.
DOGUNYE@outlook.com.
It almost sounded like a Snoop Dogg email. I had to get you to repeat it. That's what I that's what I heard at first. I said, "Excuse me." I know
yes. Yes, it is.
Snoop
But one quick
Dogg.
thing I want to say before I sign off is that
I'm
Siobhan talked about is very important because folic acid is associated in pregnancy with having neurological defects. So babies that are born with a defect, we find is due to folic acid. So it's extremely important for you to take your folic acid during pregnancy.
Thank you very much. And also obesity is associated with birth defects as well. And again, we had so many topics, we couldn't delve into them all. I just want to thank our guest, Dr. Ogunyemi. I want to thank my co-host, Siobhan, the biohacker, always giving us insights. I'm going to thank all of you for caring enough about what happens in your life post-pandemic. We have more to share. We have more to talk about, but we're out of time, so we're going to do it on the next show. I'm Dr. Cutter. If you want to learn more about me, you can go to curetology.com and take a look at my website, my office, 213-261-7100. This is Dr. Cutter, Health from the Inside Out. Be well. Thank you.
Bye-bye.